Good morning. My name is Orlando Rivera. I am a first-year graduate student at William Patterson University. And today I'm going to be talking about dilated cardiomyopathy, which shall henceforth be known as DCM. So what is DCM? First, you got to talk about what is cardiomyopathy. Cardiomyopathy is a weakening of the heart muscle. Basically, what happens is because of the specific weakening, the heart is unable to pump enough blood to the body. So DCM happens to be the most common form of cardiomyopathy. There are 4 forms in total. DCM is the most common, that's number 1. Then we've got hypertrophic, restrictive, and arrhythmogenic right ventricular cardiomyopathy. But like I said, DCM is the most common form. And what happens is basically the left ventricle gets dilated, and because of this dilation, it impairs systolic function. It impairs the ability to pump blood out of the heart. It's associated with high rates of morbidity, mortality, and it is commonly the end result is a heart transplant. Also, it's found in about 1 in 2,500, and it's much more prevalent in men than it is in women. Actually, about a ratio of 3 to 1. So the etiology. So the problem with DCM is that for the most part it is largely idiopathic. They say it's about a 60% chance that we don't know what causes DCM. But there are some genetic causes, and this is just problems that for the most part you're born with. And some of the problems that they cited were sarcomere problems. Specifically, they talked about the myofilament titin. Titin is bound from the M line to the Z line, and it regulates the sarcomere length. So the sarcomere is basically the basic contractile unit of muscle, whether it's skeletal or cardiac muscle. And the titin regulates the length of the sarcomere, which regulates the length of the muscle. So if the titin is extended or expanded, the heart muscle gets a little dilated, and basically that increases the size of it, and that impairs the systolic function of the heart. It's commonly associated with congestive heart failure, which is basically the same thing. It's just unable to provide enough oxygen and nutrition to the body. Another genetic problem is a problem with nuclear proteins, specifically lamins A and C. Another problems are ion protein channel problems and cytoskeleton problems, specifically Desmond mutations. All of these are just mutations that are just different than a normal DNA. But like I said, many are idiopathic. We don't know. So the problem is we're still finding out what the causes of DCM are. So risk factors. Like I said, it's largely idiopathic. About 40% are genetic mutations. We know of actually over 40 genetic mutations, but we're still finding out some of them. Alcohol consumption is a risk factor for DCM. Vitamin D deficiency, excess sodium, cocaine, and amphetamines. They actually broke up DCM in children. They say 66% is idiopathic in children, 16% is due to myocarditis, 9% is a neuromuscular disorder, 5% is family-related, 5% is an inborn metabolic disorder. So just a metabolic disorder. And actually it's really common seen with vitamin D deficiency in children. Actually, we talk about that later on in one of my case studies. Symptoms. So, the main symptom is shortness of breath. Basically, you go to the doctor, and what's most common is that they diagnose you with an upper respiratory infection because you're short of breath, diagnosed with dyspnea, and they give you a upper respiratory infection diagnosis most of the time. It's also common to have cough or chest pain. The other thing is that they need to make sure that they exclude pretty much almost everything before they diagnose DCM. So they need to exclude hypertension, coronary artery disease, valvular disease, an active myocarditis, excessive alcohol consumption, what else? Pericardial disease. All of these need to come to the conclusion that none of those are causing the shortness of breath or chest pain before they can diagnose DCM. The other thing is that there is no major difference between the genetic forms and the largely idiopathic forms that they don't know just yet. The only thing they'll say is that the other thing that it's family related is it's an earlier onset, so you'll see symptoms earlier. So for diagnosis, they've got a couple numbers to throw at you. There's a left ventricular fractional shortening of less than 25%. They have a ejection fraction of less than 45%. Your left ventricular end diastolic dimension greater than 55 millimeters would be considered a symptom or a sign of DCM. And they say that the left ventricle gets more spherical, so the actual shape of the ventricle itself starts to change as well. Now, the New York Heart Association has 4 classes of DCM. The first is basically asymptomatic. Let's say you have an ejection fraction of 40%, which is below 45, so you fall within the range of being diagnosed with DCM. However, you have no chest pain, no shortness of breath, so you're asymptomatic. That would be class 1. Class 2 is very slight shortness of breath dyspnea at a moderate physical activity. Class 3 is moderate to severe dyspnea and shortness of breath, chest pain at moderate to physical activity. And then there's Class 4, which basically you're unable to participate in any physical activity and you actually have shortness of breath and chest pain while at rest. Treatment. So obviously there's lifestyle modification. Avoiding excess alcohol, which is a major risk factor. Regular moderate exercise. Vitamin D supplementation, especially in children. Then from there, we do have medicine that works. They're predominantly prescribed ACE inhibitors, beta blockers, aldosterone, and vasodilators. In more severe cases, there are surgical treatments. The first is a pacemaker. This is basically described as a cardiac resynchronization therapy. And basically what happens is, because your heart isn't pumping enough blood, your heart rhythm picks up. Meanwhile, it's not really that the problem isn't that it's not pumping enough blood. The problem is that it's not pumping enough blood efficiently. So just because the heart rate is increasing doesn't necessarily mean it's working efficiently. So what the cardiac resynchronization therapy does is they try to get your heart to beat a little bit more efficiently. Another surgery is valve replacement, angioplasty, and then the final, if none of those work, is a heart transplant. And unfortunately, with DCM, the most common treatment is heart transplant. So I looked at 2 case studies. The first case study was titled "Mild Mitral Regurgitation Reduces Exercise Capacity in Patients with Idiopathic Dilated Cardiomyopathy." So in this study, there was 30 Japanese men, 30 Japanese people, 25 men, 5 women. They were diagnosed by the New York Heart Association as being either Class 2 or Class 3 DCM. They were eventually broken into 2 groups. There was one group that had what we call mitral regurgitation. So basically, the mitral valve regurgitates a little bit of blood, so obviously it's not functioning properly. So the first group was diagnosed with mild mitral valve regurgitation, MR. The second group had no MR. What they did is they put them through a ramp protocol. They put them on a cycle ergometer. They warmed up for 1 minute at 0 watts. Then they moved on it was an increase of 15 watts per minute, and they quit whenever they had chest pain or leg fatigue. The interesting finding in this study was that the patients with the mild regurgitation had significantly lower peak workloads and significantly lower VO2 maxes. So they weren't able to exercise at higher intensities. The MR group had a VO2 max of 17.9. The non-MR group, yet they still had DCM, just like the other group, had a VO2 max of 23.0. Now, there was 3 possible causes for this. They cited increased sphericity, so we talked a little bit about sphericity. Basically what they said was the changing of the shape of the left ventricle affects the mitral valve, which increased that mitral valve regurgitation. They also talked about left ventricular loading as a possible cause for this decrease in VO2 max, and the last one was a diminished forward stroke volume. The second study I looked at was titled Dual Etiology of Dilated Cardiomyopathy, the Synergistic Role of Vitamin D Deficiency. So this one took a look at vitamin D deficiency. It was a 3-month-old African boy born in Europe. He was brought to the hospital because of poor feeding habits, breathing habits, and respiratory distress. Once he was there, they found out he had an end systolic ventricle, left ventricular diameter of 0.45 millimeters. So I haven't mentioned it early on, but anything greater than 0.55 millimeters in adults would also be a sign of DCM. Now, this 3-month-old baby had a left ventricular diameter of 45 millimeters. So in adults, if it's 45 in a 3-month-old child is massive. Massive. So this child's left ventricle was extremely dilated. He also had a fractional shortening of 5%, and I mentioned it earlier. Anything below 20% or 25% rather would be diagnosed as DCM. So once there, they found out he also had a massive vitamin D and calcium deficiency. They admitted him to the intensive care unit, especially with the size of his left ventricle and the massive decrease in his fractional shortening. They gave him gamma globulin, dopamine, and milronin. After they found out that he had the vitamin D deficiency, they supplemented him with both calcium and vitamin D. And it wasn't until they gave him vitamin D that he had massive improvements in ventricular function. And he was actually released from the hospital on the 25th day of his hospital stay. So what is our role as exercise physiologists, and how could that apply to DCM patients? The first thing to understand is that a lot of these causes are both idiopathic, we don't know, and genetic related. So this is what you have. It's your DNA. So you can't change that. You can't change those things. So our goal is to improve other things. First and foremost, I should say that our goal is to improve their quality of life. Some of these people that are class 3 and class 4, they can't even move. They have chest pain and shortness of breath at rest, lying in bed, sitting in a chair. That is a severe decrease in the overall quality of life. And our overall goal should be to increase that quality of life. So I think understanding that, one, we're not going to change the function of their heart so much, as our aim really is to improve their metabolic functions in their peripheral vasculature, aiming for them to be metabolically more efficient at using ATP, metabolically more efficient at their biceps and quadriceps contracting. So we have to understand that it's not just the heart. We also need understandings understandings of just key terms like VO2 max, METs, and ECG. METs specifically, I think it's the World Health Organization that says anything below 4.0 METs has a severe increase in mortality and death. So if someone can't exercise greater than 4 METs, they're at a severely great risk for death. So our goal would be to get them to 4 METs, get them to 5, 6, 7, 8, 10 METs. I mean, 10 is actually a lot. I think that's a VO2 max of 35. But our goal should be to increase these things, and we need to understand that's our goal. Okay. Going forward, where's the future with all this? I was actually thinking about this for a while. I mean, it's kind of scary how many people are being affected by all these cardiovascular and metabolic diseases. I mean, I think there needs to be a drastic change. I don't know how to do it. You know, you see these commercials, 60 minutes of exercise, 60 minutes of play a day. You got Cam Newton in a commercial with a kid talking about play a day. Yet, as far as I know, it just keeps getting worse and worse. So, I think there needs to be major regulations on physical activity, and that sounds kind of crazy, but why can't major corporations all have a gym, and maybe every major corporation has a exercise physiologist, cardiac rehab type guy, and their goal is to monitor everyone within that corporation. All right. Whatever they're doing, everyone has assigned 20 minutes or 15 minutes on a treadmill, on a bike. All right. Now, maybe this will help decrease costs long run because companies provide health insurance for their employees. Maybe having a small gym with a exercise phys guy, making sure these people are exercising at proper intensities, will help improve all these things like DCM. Whether or not that'll ever happen, probably not. But I mean, I guess it's just an idea. Everything starts with an idea, right? And that's the conclusion of my study. If you have any questions, you can email me at the letter O, RIVE002 @gmail.com. Thank you.